So when we're going to treat a right sacral extension using the Still-Laughlin functional, we're still using the middle transverse axis for our sacrum because that's the axis the sacrum works on. There's not a torsional component in there, so we're staying right on the middle axis. So like with our left sacral flexion, we want to get on the PSIS level, except this time the problem is on the right. So you want your hand kind of at the nape of the neck, here more than out here, so that you're going to be able to get the vector force, because what we're going to do, translate to the middle transverse axis, so we have maximal motion at the sacrum. So now we ask ourselves, which way is the sacrum looking? Well, with a right sacral extension, the sacrum is looking to the right, so we want to load the right ischial tuberosity. But then our dysfunction is also on the right. So having your hand at the nape of the neck will help you with your transition to be able to load and float the same side. So middle transverse axis, and we're just gonna side bend till we feel the ischial tuberosity drop to the table. I don't know if you could see, but you could even see the hip would drop down when we've got that loaded. And then so maintaining that, if you back up just the least bit, right there, loose packs and floats this dysfunctional joint, so we have maximal motion. So we're still loaded to the right, but then we floated this right SI joint. So our vector force is going to come in this angle down. Again, kind of imagine you're trying to get your hands to reach. So then you load, and once the tissues start activating, then you're just going to follow, but maintain your vector force. Do not let up. That is the biggest component that people mess up on to get the technique not to work. Okay, and then it's gonna come right around. There we go. She did not have a right sacral extension, so we didn't get as much of that still point that you could if the dysfunction was exactly there. So again, 30 seconds or less, you should be able to resolve it. If there's motion going fast and it feels like it's dancing, think of that you're taking the long road instead of the shortcut, and you usually need to either localize more, but most of the time if you'll just load in a little more activating vector force, then you'll get the buoyancy of the tissues to soften up, and you're not actively taking the patient through the range of motion, you're just maintaining and following. And if you feel like the patient's wanting to guard on you, you always can put your head in the center to kind of give you an extra little balance vector force point there.